have that legislation in place to protect the physician and certainly the patient. At the federal level, and I'm glad Dr. Korb is on tonight, he's been involved with this. There are a couple of pieces of legislation, and I'm sure there are more, but one is, and they actually both are sponsored by Bill Cassidy, Senator Cassidy from Louisiana. The most recent one he has that he's trying to garner support for is a piece of legislation regarding price transparency. And there has been another piece of legislation called the Primary Care Enhancement Act, which would essentially, that's probably its sole purpose, is to allow for the use of HSAs for direct primary care or direct pay membership fees. Currently, that's not allowed. That's not a qualified expense under the current HSA legislation. So those two pieces at the federal level are very important to keep this movement moving forward. Is there anybody that has any questions or input on that? Dr. Corbett, did I fairly well summarize what Dr. Cassidy's trying to do? Dr. Corbett may be watching the volleyball game. Okay.
No, can you hear me?
Yes, go ahead.
Can you hear me now?
Yes.
Okay. Yeah, just to add to that, that was a good summary. There's a couple other bills floating around that address HSA usage with chronic care, cases of chronic, several of those, and that would be helpful for DPC, but it wouldn't help with acute visits that families enjoy when they're members of a DPC practice. Bill that I was asked to speak about, and that's 5138, House Bill 5138.
So that's the one that we really don't want to see get enacted.
Yes, now there were some good parts to that because chronic care and HSA usage was mentioned in that.
Right.
Also some language about the FSAs and the HSAs and the HRAs.
Okay, well, thank you. Another area that we thought would be interesting to discuss is the area of scalability. And what that means is if we want this DPC movement, this concept to move forward, is scalability necessary? And we hear varying thoughts on that, especially related to large companies. I saw some good information from Dr. Korba just this evening. I think there's differing viewpoints on employer and DPC. And a good point that Dr. Korba made was if you have a large employer that basically makes up 75 or 80% of your patient base, and they decide they're going to do something different, then what do you do? So scalability certainly can have some application from that standpoint. Is it important? I'm not sure that's the right word even. I think that there's a growing effort to get DPC physicians, whether they be direct patient care, direct primary care, whatever you want to call it, to have a unified voice. And so I kind of prefer to lean that way a little bit. In other words, share information, have a place where all those physicians that are involved in this practice model can come together and benefit from each other's knowledge and experience. But I've heard the word scalability mentioned by employers, and people have asked me questions, how do you scale this up? Again, I don't know if that's the right word. Anybody have any thoughts on that or want to tell me to move on?
Well, I think that, for me, I think that is key, because maybe just frame it in terms of the problem. And the problem is it's nearly impossible currently to bootstrap direct primary care. And that's because, as everybody who's involved with it knows, it's a one potato, two potato membership enrollment, and it's word of mouth. And it's difficult to get a physician to leave an employed situation when you tell them, we do not have patients for you, you need to go open up a practice and do it one potato, two potato. They have bills to pay.
Right.
They have, obligations. They have house payments. So that's impossible. But if you could present them with 600 patients and say, here is an opportunity to actually be able to practice medicine the way you always wanted to, or the way that you were trained to, or the way it was meant to be. And here's an opportunity that already is given to you basically on a platter, where you have 600 patients, 400 patients, and you don't have to worry about bootstrapping it. So that's where I think scalability is important. Until you have that, this thing is just probably will eventually die on the vine, because you will have those people who are very energetic and maybe high risk takers who will start a practice like this, or those who are financially capable to be able to take that risk.
Mm-hmm.
And then the rest are going to stay employed or traditional practice where they're credentialed with insurance. So that's the problem. So I think what Brennan is looking at, maybe you can correct me, is a way to bootstrap this in a sort of a decentralized network where you take out all the middlemen and all the expenses associated with all the middlemen and all the extraction in healthcare, and allow this to happen automatically bootstrapped by automatically engaging a network. So that's what I'm interested to hear tonight is how is that process, and what mechanism of enrollment will occur, and how do you do this in a way that avoids government involvement, avoids regulators, and remains completely legal?
Yeah, it's a good point. And Lauren, I don't know if you saw that email I sent you earlier, but something we're working on is a concept of health as a service, or healthcare as a service, and it's specific plans. One being a direct primary care monthly membership, then you have cancer care, cardiovascular care, mental health care, and you're subscribing to services not only from a direct care provider, but also other specialists that we're hopefully going to grow out a network of. It's the concept of having this one large nationwide network of physicians and care providers, and also having this nationwide network of patients and self-funded employer groups that are looking for direct primary care or direct care physicians. And having these two networks come together on a decentralized platform is what we're going for. And if you look at just the typical subscription to healthcare now with direct primary care, what's the average? $75, $90 a month. It's somewhere around there. That it's cost effective for the patient with a high deductible plan, and also with self-funded employers. So if you do the math and you start looking at these subscription services, almost like a Netflix subscription, it comes down to it saves a whole lot of money for this country. And at scale, it works, but getting to that scale, I think that is the hardest part. I mean, that is kind of the key to all this. How do you get to that X number of people where it takes to have direct care network across the country in every state? Because we had a conversation this morning. What if I have a direct primary care here in Hattiesburg, Mississippi, but I go skiing in Colorado, and my son has a sore throat or something, and we need to get a prescription for something? Well, I would like to go see a direct primary care physician in Colorado that is in this network, this peer-to-peer owned decentralized collective, so to speak. And that's the concept, is going anywhere in this country and later on into the world and having the same level of care and access everywhere you go. And everybody is in this together, and the incentives are all aligned for everybody to be involved with this. So that's kind of the concept. Is in terms of the regulation, I do think that things are becoming more favorable for this type of subscription model because we got 25 states now that say this patient to physician contract does not fall under insurance regulation. And I've read the majority of it, and it seems to me like a subscription to healthcare services still does not meet the insurance requirements that I've looked at. So when we add in this other bill we've been talking about, being able to pay with your HSA, which is another thing we're looking at. We're developing a personal health asset. Still working on the name, but it functions like an HSA, and we're looking into either partnering with a bank to provide our own HSA or just do it ourselves. And if you get down to it, starting an HSA, like an actual health savings account for people, it's not that hard. I mean, there's a few requirements that really any investment company can meet those requirements. So easily to partner up with a bank to do that, but that's not really the point of this. But the idea is to tie these different assets in to make the whole system work. You have to have a way to pay for it. You have to have a platform to bring the consumers of healthcare to it and the producers of healthcare, the health providers, on this decentralized platform. So I guess that may have answered your question.
Well, it's partially. HSAs are regulated, and they will always be regulated. And so that would be a problem in a distributed network system where you're trying to avoid regulation. Direct primary care, for the most part, is not regulated. And in a few states where they have regulated, like New York, where they've disciplined some direct primary care physicians, they've been fairly capable to get around those regulations. Insurance, of course, is highly regulated, and an employer plan is highly regulated. The only non-insurance that is not regulated is health sharing plans. Health sharing plans are not regulated because they do not claim to be insurance. They don't claim to actually cover anything. They in fact say they don't cover anything. If you pay the membership fee to a health sharing plan, you're doing it at your own risk. They don't guarantee coverage for anything. So I think doing that type of thing might work with the decentralized blockchain network until the regulators decide they want to regulate that. But I don't think there's really any other way to do that. To obligate anybody to pay a membership for catastrophic plan or for a major medical plan in any other way at this point is just too highly regulated to make it work. And until you are able to couple some sort of a major medical plan to DPC and then sort of make that available to everybody in a networked, either a blockchain or among a consortium of direct primary care physicians where they can all put their name in that pool and have enough physicians available to either employers or individuals. I just don't think it's going to be scalable.
It's going to be we're talking about people, so it's kind of hard to scale people. But at the same time, if you create a platform that allows easy onboarding for physicians and almost like I'm not going to say a franchise model, but a standard model for physicians that want to leave the employment practice and go out on their own, venture out on their own. I guess it would be a franchise model, but have something kind of set up and clear that they know exactly what they're going into. They will have a kind of a set number of patients that are in their area that they can go ahead and bring on. That's the only way I think it could scale, is if you have a clear blueprint for new doctors to come on board and scale it out that way. Because like you said, it turns into a lot of risk and really an entrepreneurial pursuit to go out on your own and start fresh with no patients, and you have to learn how to market, you have to set up a website. I mean, a lot of physicians don't want to do that. But at the same time, a lot of them do. And if you provide a method for them to easily do that, I believe a lot of people will start to do it. And I think there's, John, you've been helping physicians do this, and I think there's a few other people that are helping, that are guiding physicians through this model, and I think it's being successful.
Do you guys view it as not a binary thing? I think some of the conversations at the real heart of the supply and demand of this, one is, what's the value proposition on the demand side, and is that clear? But you guys are kind of talking about the supply side, and there the value is more clear, where you don't have all the regulation and claims and people are paying you up front. But is it do you have to fully cut over, or do you guys think there's a way where you can start testing the waters, do this as a side thing, where you see physicians today do the telemedicine stuff with HealthTap or Sherpa, that there's a few companies where you can sign up and like, I'll be in your network, and if I'm available, I'll take some telemedicine calls as a side thing. Do you see a path where people can try it out in some similar way without being fully direct primary care only, and keep kind of, keep their foundation until they get a big enough patient base, member base, and then can cut over?
Well, that might work for somebody who's already independent, but it's not going to work with an employed physician. The employer is not going to allow that.
Can you guys hear me?
Yes.
Hello? Okay, that won't work because the physician has to be opted out. If they're still under contract in their current employed position with insurers or carriers, they cannot, by contract, charge monthly or periodic or whatever you want to call it, periodic fees without opting out completely.
Okay, so it is.
Hey, this is Ellen McKnight. I was going to mention this one thing. There's a Dr. Lee Gross who's out of South Florida, and he's been very big in the direct primary care movement here in Florida. And he came to speak to our medical society a year and a half ago, and he does a hybrid model where he still accepts Medicare. Now, I mean, I'm an opted-out doctor of Medicare. I don't know how he does that, but he is doing both, and I think the goal for him at some point will be to transition fully over to direct primary care. Now, he was doing direct primary care in Florida before the law passed just literally a week ago. The governor signed it to free the doctors from this burden of being called an insurance company. So he was doing it then, and it may have something to do with that. But at least I know of one model, and he is on the internet, and I'd be happy to share the information of how you could find out about how he has done a hybrid model. So that is out there, absolutely. And I don't know how it's done, but we should check it out.
If I can piggyback on Ellen's comments, I can tell you Lee Gross does not advocate a hybrid model for multiple reasons. And he had to do that because they had an overhead to meet when they transitioned their commercial from the commercial insurance to DPC, which is what he opted out of. And they own a building, and they had overhead that they had to pay for. So that's why the decision was made not to opt out of Medicare. But if you talk to him, he says it's very difficult, and he doesn't advocate for it, although there are doctors who are doing DPC that have chosen not to opt out of Medicare yet for the same reasons. They also don't want to give up their Medicare patients, a lot of them. So it is difficult to do both in the office as far as a billing and a procedural, intra-office procedural type thing, but it's possible.
Yeah, I mean, there is a model out there, whether or not it's a great model, and in fact, in my own experience, I opted out of Medicare first. In fact, right now I'm still in the insurance world, but I'm getting ready to start getting rid of those one at a time, hopefully, as I keep going forward. So the hybrid is out there. Again, it's not the best. The question was, is that a possibility? It is for doctors who are in practice who might be in a situation like that. So it's there, again, not the most desirable situation, but the model does exist.
Right, and so if you wanted to bring on board doctors to dip their toe in, like you guys were talking about, if they were still participating with Medicare, that would be possible. but if they are still participating with commercial insurers, they by contract with these insurers, they couldn't see direct pay patients in a separate practice. But if you go on DPC Mapper, Phil Eskew's site on DPC Frontier, you can actually pull up a map of the United States, and he color codes each practice that has registered with him,
right,
by whether they're pure DPC, meaning they're opted out of everything, or they're a hybrid model. So you guys can actually go on and find hybrid models and reach out to them, see if they can answer some of your questions.
Thank you. That's helpful.
Yeah, I think you lose part of the benefit of the direct primary care model when you're doing a hybrid. You lose the cost savings that you get because you're still having to staff insurance folks, claims, all the other associated hoo-ha that you have to do in the insured model and the Medicare model. You're still bound by, if you want to receive, quote, maximum reimbursement, you're still bound by MACRA and all the other regulations. So from a standpoint of cost savings and being able to run that practice lean, it makes it more difficult. And correct me if I'm wrong, doctors, please.
No, you're right. You're going to still have that overhead there. I mean, I'm completely opted out of everything. My overhead dropped by 40%.
Right.
And it also freed up my ability to practice more attentive medicine in the office for my patients. When you have the distraction of still participating, it's definitely harder.
Well, and you have a semblance of a life.
Well, it's not a walk in the park doing DPC. By the semblance of, well, you know what? My life is not dictated by others. That's
what I'm getting at.
Put it that way.
You have the hard work is still there, but you're at least directing it.
So, Kim, let me ask you, I'm kind of curious, what is the hardest part of this transition to a DPC practice?
Oh, well, you're asking the right person, because I had a 13-year-old mature private practice that I transitioned to a little over 2 years ago. And the hardest part was the marketing and convincing patients that it was a good idea, and then providing, you're out there saying you're going to provide this service that people aren't used to. First of all, it's a foreign concept to them because they're used to the current system. And then, so you got to put your money where your mouth is. So, I'm promising the sun, moon, and stars, you can provide that. But then on top of it, you're super nervous that you're not doing enough to justify the pennies to dollars a day that they're paying you, which is literally what it is. And they're managing the patient's expectations is very hard too, because it's almost like they're walking in the desert, they haven't had water for years, all of a sudden there's an oasis and they just want to dive in. And so sometimes we have utilization issues. So there's a lot. I could talk an hour about the wonderful parts of transitioning and the very difficult parts. But definitely the marketing and the financial risk are two of the biggest things. Doctors are not business people, and they don't know how to market. And you have to say this, you have to present DPC, tied up in a nice package, because it's hard to understand. So the more you postulate on it and talk about it, the more confusing it gets. You really have to get your marketing points very clear, concise, and quick. So you engage them. And that I would say those are the two biggest parts, is the patient expectations and the marketing. 3, the financial risk, number 3.
I'm curious, out of your previous patient load, how many of those patients transitioned over to your direct care practice?
Well, Josh Umber was my number 1 supporter and mentor. And Josh said nationally at that time, and that was the end of 2015 when I did my transition. It was the last 3 months of 2015. He said at that time the average was 10 to 15% would follow you. And I had, out of my active, I had 2,500 charts in my office, in my EHR. 1,200 of them had been seen in the previous 2 years, and exactly 120 followed me. So it was 10% of my active patients. So he was right on the money with that. Now, might say at this point now, almost 2.5 years in, I'd say, I think probably about 60 to 75% of them have stayed. And what they said is the ones that you don't expect to stay will, and the ones that you expect to stay won't. And that was absolutely correct as well. People who don't have 2 pennies to rub together find the money to come to see me every month. And it's been a really interesting observation for 2.5 years on human behavior. We also have people finding us, well, mostly it's people who are falling through the cracks and been lost in the system. There's a huge population of gappers. We've called them, a bunch of us have called them gappers, people who don't make too much money to qualify for the subsidies, but make too little to comfortably afford anything on the exchange. Those people are opting not to have coverage at all. And they're coming to us for their primary care, which puts a lot of pressure on us, because if there's an issue that's outside of our scope of care, we are happy to bust our tuchuses to find them, cash prices or help them get the specialty care they need. But that's very risky with those patients, and it's risky for them financially. It's risky for us professionally, but that's another big problem. So those are the patients that have been finding us. And we all, I do have a bunch of patients that have great insurance, teachers, policemen who have great coverage, county workers, and they're coming for the access and the time and the ability to get in to be seen the same day or get us after hours. And then we have the uninsured coming. I have patients on Medicare and Medicaid who are paying out of pocket for the access and the extra attention. And we have the health sharing ministries. So it's kind of a smorgasbord of patients who are finding us and finding value. I get tons of comments, and in fact, I just did at my son's volleyball game before I got on the call with you. One of the moms said, and this is very, very typical, I've heard it from other people, I wish my insurance was it wasn't so expensive, or I would join your practice. And I said, do you have a high deductible? Yes. I said, okay, well, we have patients with high deductibles who are joining and just not putting their meds, labs, or imaging through their insurance. And they look at me like it's a foreign concept, but that is happening. We have patients who are just avoiding their deductible completely and taking our cash price. And they're saying the money they're saving on their MRI or their Z-Pak prescription or their annual blood work, they're putting that aside in case they need to meet their deductible for some reason. And the public's starting to think outside the box, but not completely yet. So there's a lot of interesting changes going on in the way people are starting to look at what they're paying for. Mm-hmm. Now, getting back to how that affects DPC practices, I kind of summarized that a little bit, but that is also regional. There's different behaviors on a regional level. The Northeast has been a really tough market for us up here. In the Midwest and down south, it definitely seems to be catching on much quicker. And I don't know why that is. Again, that'll be interesting to look at retrospectively, but I don't know if I'm helping at all by giving you this
Absolutely.
Very valuable stuff, and that it leads me to some numbers I want to share. I want to share my screen real fast for everybody that can see this. You can hit on some things I think might be relevant. Let me see. Can everybody see my screen?
Yep.
See numbers? Okay, Citizen Health. I'm trying to, where's my Zoom thing at? Okay, so everybody can see these numbers, right? It starts with 327 million Americans.
Yes.
Okay, yeah. So this is some calculations I did, and it's It's self-explanatory. You can see how many people get their insurance through employers, Medicare, Medicaid, and so forth. You can see the actual premiums paid by these people. All the American people, with the employers and the employees and just individuals, people covered by Medicare and other government plans, the premiums alone we pay is close to 1.2 trillion. And then you have close to 350 billion in out-of-pocket costs, as copays, deductibles, and also about $800 billion are withheld out of our paychecks for Medicaid and Medicare and other government programs. So you're looking at about $2.4 trillion is paid into the system by the American people. And then if you look at the other side of this chart here, you look at every physician, primary care specialists, you got practitioners, the nurses, physician assistants, you go on down the list, every single health provider, I'm lumping everybody together, the average salary for these people is $583 billion. And if you look at all the hospitals, I'm hearing an echo. If you look at all the hospitals and all their operating expenses, can anybody hear this echo, or is that just me?
Yep, I hear it.
I'm hearing it.
Someone needs to mute.
Yeah. So anyways, you can see this. It actually costs for all operating expenses for healthcare in this country to pay the salaries for every health provider, and also the operating expenses, which include the salary for the hospitals. You're looking at $900 billion. We pay $2.4 trillion, and it costs, might as well say, $1 trillion to do all this. Got an extra $1 trillion floating around there. And where does that go? That goes to the for-profit or non-for-profit and for-profit insurance companies in the middle of this, making their cut, so they can facilitate our money transfer from the patients to the physicians, which doesn't really make sense when we have this newer technology that can automate a lot of that process. And then taking it a step further, you can't see it on this chart, but I figured out the top 100 procedures that were performed in America this 2015, and it kind of makes up just about everything. And I was looking at the cash price, the direct payment price for this, and I got a lot of these prices for surgeries from the Oklahoma Surgery Center, and also Healthcare Blue Book. There's a few services out there where you can find cash prices, and every single procedure done from birth to death for everybody in this particular year, it costs around $900 billion. You might as well just round that out to trillion. So everything paid in a direct pay model costs $1 trillion, and we pay 2.4 trillion. So what I'm getting at is the American people pay enough to cover everybody, to pay for every single procedure done, but having these intermediaries extract that value before it gets to the actual hospitals or the care providers, it's messing up the whole process. So when you remove that $1 trillion monster in the middle and you replace that with something like a peer-to-peer network, smart contracts, a blockchain, decentralized network, you can potentially save $1 trillion for everybody. What do you do with that $1 trillion after that? Does it go back to the people? Do you redevelop or refund that back into research and development for cures for diseases? There's so much stuff you can do with that. And that's just a number I wanted to throw out there and let everybody see it, since we were talking about some of the out-of-pocket costs. So this is something that I've never seen calculations like this, but Ben, we kind of talked about it before, and this is about the same calculation that we came up with at one time.
Yeah, I think there's some cost. There is a substantial cost to medications that maybe you're not putting in, and but besides that,
that's only
obviously it still doesn't pass the sniff test, even if you add that. I think
the pharmaceuticals, it's either 350 billion or 450 billion, which still, I mean, you still have a lot left over there.
I mean, the reason for insurance is to hedge for risk. So I mean, that's why it's there. And why don't pay for healthcare based on a global cost or a regional cost. They're based on what their risks are. That's where we have actuaries doing that. The only one that doesn't are the health sharing plans. They have no actuaries. They just base it on you giving your trust to, or faith, entity that says they might pay your bills. And I don't really see really any other way to do it if you're going to do it on a blockchain. The only other way would be to network around a sort of a wellness idea. And wellness plans are also not regulated. Almost many of them are used by, they're regulated in some ways because they are used by employers to decrease their tax burden. But, other than that, there's not much regulation involved with. So I don't know how you would do this. How would you create an insurance on a blockchain without invoking a lot of regulations? Because it is a risk-sharing entity.
Well, you say it's a risk-sharing entity, but not if we do the health sharing route. For example, let's just kind of just walk through my thoughts. Let's just say everybody starts with $100 a month. You're subscribing to a health and wellness plan that includes free access to you. That's their start with $100 a month. And then let's just say if this is at scale, we do say we have 327 million Americans on this. And the next month, let's just say we have some large surgery we got to take care of. And now, instead of $100 a month, the next month, people will need to pay $102 a month just because those costs went up. And maybe the same thing happens next month. Now, everybody has to pay $105 a month. And then maybe the next month, the claim services go down and they're back to paying $102 a month, something like that. So the idea is
you'd have to convince individuals that they're giving money without any promise of coverage of anything.
Well, yeah, it's definitely going to be a selling point to this. I think in a way this can almost start off as a premium service to people that to want to be healthier, to excel in their health. Now, I say a lot of things like, we want to try to get people that are unhealthy to at least baseline to that healthy status. And if they're there, to keep them there, or if they want to excel and optimize their health, we can do that. I think that the people that want to optimize their health, we can focus on a health and wellness plan for them that is not necessarily going to cover a car wreck, but it is a direct service or a subscription to a physician that can help them through their diet or whatever problem is they're trying to work on. So that's one avenue we can kind of go down, is looking at that premium route and then try to grow it out, almost like the Tesla model. You start at the premium, then kind of coming down to the cheaper models. That's one way to do it, one way to think about it. But the health sharing ministries, now you're talking about the regulation with that. Now, I don't think anybody can start a health sharing ministry because there was a handful of them that were grandfathered in a few years ago.
Well, anyone, I think any faith-based organization can start a health sharing ministry, just they're not ACA compliant. The only ones that were grandfathered in were the ones that were actually in existence before 1997, I think it was, but I'm not sure about that date. So that's the part that's regulated. They're not, if they're ACA compliant, they don't pay the fine. Well, that sounds like that's going out of, that's not no longer going to be in existence because of the tax bill.
Right.
So that's really not even an issue anymore. So I guess the question is, what faith-based entity would the blockchain be that would allow you to start a health sharing plan?
What is that religion people were talking about now? It's some blockchain-based religion. I forgot what it was, but I'm drawing a blank. But does it have to be a certain? I guess what is a religion when you get down to the definition in law? Like, what would that be? Is there a way that you can just have a broad digital religion? I'm not trying to get around certain things, but I mean that's a legitimate question. Like, what are the specific criteria for that? Kind of curious.
I don't really even know if there are any criteria is based around it, since it promises not to cover anything. I mean, they all do cover. You know, most people are very happy with their health sharing plan because they actually do cover things that are submitted, and probably only about, I think, Liberty Health Share says they only refuse about 7% of applicants and cover 97% of claims that are submitted. So, you know, under their criteria. So, I mean, they do cover them. I think if you want to do this, you really kind of have to maybe get in one of those networks and discover how they do it. But that may be difficult because, you know, I think they're pretty closed. I don't think they're very open as to how they manage these things. So
there's also a new health sharing plan that's come to my knowledge. It's called Sabira Health. It is not a faith-based health sharing plan. So I haven't had a chance to look deeply into it, but it's interesting. Every other one that I know of, Christian Health Ministries, Liberty, MediShare, all those are faith-based, but this one is not. And I know they're making a big marketing push right now on the fact that they're not. They have some requirements, like you can't be doing illicit drugs or any of that. But it's interesting that, and they say they are ACA compliant, but as you said, Dr. King, it really doesn't matter much anymore after January 1 because that's not going to be an issue as far as having a penalty.
yeah, Sedera is ACA compliant because they use Samaritan as their health sharing plan.
There you go.
And so that's been around for a while. What Sedera has done is they've added a MEC plan to it, and then they sell it to employers. And I think the employer size is between 3 and up to 200 or so. I think that they find that, yeah, small employers, which, you know, that's an area which would work with DPC. And I actually am a member of Sedera, my family is. So, and because we're small employers. And it works for DPC because you're not putting yourself at risk with a large employer and losing all those those patients in one re-up year, you know, where you find yourself bankrupt because you lost all your employees. And you're also not under the power and belligerence of an employer who may want you to do things you don't want to do. So I think it does work well. Again, it's you know, maybe something like that could be put on a blockchain and automated. But, you know, it's just, I think that's maybe who you need to talk to. Talk to the people who actually run Sedera.
Yeah, I'll definitely look into them, and they're in Austin.
Right.
Interesting. And how long have they been around? Do I know?
They just started. It's just new. There's another one called Alir. Alir is also, it's faith-based, but it's not any specific faith. And they, you know, don't have restrictions on same-sex marriage or anything like, you know, those types of things. They just have a few criteria that they follow. So I think it has to be based around criteria. And, you know, I was going to read a little excerpt from what's required in health sharing plans. If there was to be a direct primary care health sharing plan at some point.
If I can jump in, Sedera discounts premiums if you enroll with a DPC practice.
Right. Yes, they do.
Another thing that the health sharing ministries do is they negotiate with the hospitals and other healthcare providing entities for cash prices. They have a whole department that negotiates. I know Liberty does. I think MediShare does as well.
Christian Health Ministries does as well. My wife is a member, and we have found even with for-profit hospital facilities, it's a minimum 50% discount for certain services. So, but the thing that Christian Health Ministries does, they put a little bit of the onus on the patient, which is a good thing, in that you kind of got a little more skin in the game if you actually call the provider and say, I need this service. I'm a member of Christian Health Ministries. What is your cash price, or what would be the cash price for this particular procedure? Of course, half the time you get the answer, I don't know.
Right.
We
get that in DPC.
Oh yeah, I'm well aware. But the other thing is, with the price transparency resources that are becoming available, the local hospital where I live wanted a couple of grand for an MRI brain without contrast because they think they can get it. And I see Dr. McKnight jumped off, but in Pensacola, I found an independent multi-specialty physician group that did it for $375 all in. Significant savings. And, people have come to me and said, well, that's great, but I have a deductible and I'd rather pay $800 or $1,000 so I could meet my deductible. I'm sitting in my head going, wait a minute, it's your money coming out of your pocket. Why would you do that?
That's the culture that has to change.
Right.
And I can tell you, though, in a little over 2 years again of me doing this, the culture is slowly changing. I think we've had this discussion in our DPC groups, people have to bleed first before literally have to be hurting so bad they're bleeding to make this cultural change, to think outside the box. But it is happening. It is happening.
Yeah, I'll say the biggest problem that I'm seeing with direct care, this whole entire model, is people not knowing about it. And you said the education part. I mean, I've been to multiple blockchain conferences, and people have never even heard about direct primary care.
Yes. Well,
if I could interject from someone who's working with the homeless and the indigent and the lower income classes, they don't know what blockchain is. And they are so worried that if they don't use their health plan and then eat up their deductible, that if something serious happens to them, that they won't be able to afford it whatsoever. So that's why they're scared to move away from it, a lot of them.
That's true. That's very true. Yep.
Yeah, but then you think of all the millions of people that have even fairly low deductibles, but we're teaching them to be healthy, trying to, and certainly our physicians are, and they're never going to reach their deductible or their out-of-pocket max. That's a good thing that they're healthy, but
now, I'm sorry, but nowadays with the population, it's going to be over the age of 60, requiring higher medical care coming up in the next 4 years. It's going to become a big issue, and these people are the ones that are going to be a drain. Not that anyone's a drain that's older, but they're going to start, and they're so entrenched in the usual way that I'm worried that they're not going to change. So maybe you get them when they're really young, or they're just coming out of college and they're hip with what's going on. The buzzwords. That's where the culture might. I think that's where you have to focus to get it to finally be adopted, is with the younger ones, because a lot of the other ones are just too entrenched in the way the status quo is now.
Yeah. I'm looking at, we're talking about educating individuals about this. I think the easier route might be going to self-funded employers and small businesses and going straight to them and creating a network of employers that understand this model. It's kind of an easier sell when you say you're spending X amount a month. This is your budget. This is how much you potentially have to have reinsurance there. But I think it's an easier sell to self-funded employers, just because they can predict what their healthcare costs are going to be for the most part. I think a lot of them, or I know a lot of larger self-funded groups, they're going straight to direct contracting for surgeries and specific events. And so they understand that. They understand that direct contracting model. So I think moving to this direct primary contracting model, it would be an easier sell for them. And once you have a large employer, they just kind of tell their employees, hey, this is what you're going to do. And maybe that education kind of trickle down. That's just my thoughts on that.
And that's already happening. There's scaled up models that are already going to employers. I got a call yesterday from Mason Reiner, who's the CEO of Our Health. Our Health is a corporate DPC model with investors in greater Philadelphia area and South Jersey. And I'm about an hour north of Philly. And he called me yesterday that he has an employer in Bucks County who has about 100 to 200 employees who live in the Lehigh Valley up here where I am. And he wanted to know my interest in working with Our Health to take care of those employees. And that is just one example. But Iora Health is another one that's doing it, Paladina Health. And they're hitting the employers, the self-funded employers, very, very hard. And they're jumping on.
Yeah. But those aren't independent physicians, or are they? Do they contract with independent? Okay. So
that's the problem.
That's again,
the problem. Yeah.
Right.
You got a really independent, free-thinking, sick of the system bunch of doctors who don't want to be paid by a middleman anymore. And that was my issue with the call yesterday. You know, he's going to determine what I'm getting paid, and he wants to tie data collection to it. You know, and we all understand that the employers are going to want to see some data for cost savings, but the way it's being done, and you have to abide by the rules of the corporate DPC model that you're agreeing to partner with. And they could change how much you're getting paid every month. And, you know, if I take 100 or 200 employees into my practice, which was my post today, the reason for my post today that John quoted in the beginning of this call, you know, that if that employer deal falls apart, I have between 100 and 200 patients exiting my practice. And so there's lots of parts to that is not appealing to DPC docs. They would rather be paid directly by the patient, have the employer reimburse the patient for the membership fee. You know, that changes the whole doctor-patient relationship when the patient's handing you the money, even if it's being reimbursed by the employer. So there's lots of parts, you know, but there are some docs out there that don't want to run their own practice and would rather be employed in a DPC scaled up model. You know, so it's really, right now, the population of DPC doctors is not thrilled with these ideas. But, you know, as we try to recruit more medical students and residents into the model, which is happening, and hopefully there's more interest in going into primary care, you might have a population of younger doctors coming out who don't want to take the financial risk of opening their own practice and who might jump on this. But that's not happening really fast. That's another cultural shift that has to happen in the med schools.
It's just another intermediary is what it is, really.
That's right. That's right.
Do you guys view along those lines, doctors tend to join groups all the time today anyway. Do you guys have your own networks of DPC physicians? So you're not letting people go at it alone just because they want to go get paid directly or be in more control of their practice or less regulated, but they can still join a group of physicians, and you know, you help cover each other's patients, and you do the other thing, and you have maybe negotiating power if you end up deciding to go to employers versus being your own business. Are physicians still thinking, are DPC physicians still thinking that you need to band together and form your own groups like you've had to do?
Well, no, because it's really growing organically. But what we do now already, because we have, you know, the DPC mapper, we have connections in social media groups, and I did this, and other doctors did this. If we have a patient that's in another city that's ill, we get on the horn and we call and it's, another DPC practice, and we say, hey, can you see our patient? And what they usually do is just charge them a one-time fee to be seen. I had a patient who was in Raleigh, North Carolina on business, and he called me. He had an issue. He sent me a picture. It was a cellulitis. I called Amy Walsh, who's in Raleigh, and I said, hey, Amy, can you see my patient? Sure, send him over. And she charged him a one-time fee of $50 and got him taken care of. He was going to go to urgent care. And so we're doing it organically, just by reaching out to each other.
And what a network would you look to, if the way you would collect membership fees and get paid through like a citizen health type of platform, would you also look to that platform to help you organize formal groups, whether they're regional or maybe not regional in the case you just gave out, but or would everybody actually, participation in this kind of network imply you're all actually part of a group that's going to honor other people's membership fees that aren't necessarily your patient list? Like how do you?
I think that takes away the whole reason why we're doing this. I think the organic growth is really important, and you need to remember that we're all fiercely independent. And
the piece that's missing, though, is but I think the piece that's missing again is, physicians, direct primary care staying independent, having their own contract, independent contract, sovereign contract with the patient, and then being able to give them a reliable catastrophic care plan that could be used anywhere in the United States. That's the piece that's missing. That's the piece that would tie us all together. There just isn't anything out there yet, and I don't know why. And maybe it's because there's just not enough of us to demand it. But it's a chicken and the egg problem, and that's the biggest problem, I think.
I agree, and I'm surprised there hasn't been a company that has jumped on this yet, and whoever jumps on it is the winner, because after being in Washington last week and being included on some really closed meetings with some lawmakers, the reason I really pretty sure reliably the reason why there was no health care provisions put in the omnibus is because they don't know what to do. And I was in a meeting with Congressman Roger Marshall and about 10 other physicians, and he gave us homework to do ahead of time, and his primary, our assignment was analyzing the healthcare bills that are around there, floating around, some that have passed, some that are just proposed, and applying that to how the AHCA affects the high risk pool and the chronically ill. Their big hang up, and I'm tying this into what you guys are talking about in a second, but their big issue is throwing more tax money at the states to prop up the insurance companies. They can't keep doing that because the rates are going up. It's not helping keeping the rates down. So whether or not and how much they decide to throw at the states isn't fixing the problem. And what's going to happen, and what we think is going to happen, is that people are going to be shopping. They're going to start bleeding, like I said, and they're going to start shopping for alternatives. And it's going to be these high deductible plans that are costing them less out of pocket every month. And the word is spreading. And if Cassidy passes this transparency bill, which I heard might have the Primary Care Enhancement Act attached to it, he passes this transparency bill, and people are going to start shopping, just like they go to Costco, just like they shop online using their coupon codes. They're going to, that's what's going to happen. So even if the government props up and throws the CSR and the stabilization funds at the states to prop up these insurance companies, they're still jacking up their rates. And you're going to have people very quickly, it's happening already, starting to try to find a more affordable option that covers the catastrophic issues, and then find a network where they can get their basic care at an affordable price. I mean, most of us don't even feel like primary care should be an insurable expense.
Right.
It shouldn't bankrupt anybody. It can be done affordably, and we're showing that in DPC. So you carve that out and give people the power with their HSAs or an employer reimbursing them for their primary care, and you give them the power to shop their doctors. And if I'm charging $75 a month and Dr. Smith down the street is charging $50 a month, and I'm a better doctor, they're gonna pay for the 75, or if they don't care, they'll pay for the 50. But you gotta give the people some of the responsibility with their money. And that's where the organic part comes back in with the docs. Like we love the fact that we can just call up each other and say, hey, will you see my patient? And everybody's like, sure, just $50, one-time fee, and I'll call you as soon as I'm done with them, and I'll let you know what I found. I mean, it's a beautiful thing.
No claims, no copays, no deductibles.
Nothing.
None of that.
No, just pure communication between us. Yep.
I'm fairly certain, though, if the government's going to get involved with any of these bills pass, it's going to be extremely complicated and eventually obfuscated by those that pay the money to play the game.
Well,
yeah. And that's why I really, really like health sharing plans. They completely avoid that, and nobody messes with them, I guess, because, it's a mixing religion with state, and that's why they're keeping their hands off. But that allows those plans to have a lot of freedom, and to do things that no other insurance can do, and not be interfered with by states. If you look state by state, almost every state has some sort of policy about health sharing plans that they really don't get involved. They don't regulate them at all. They have nothing to do with them, and they basically say, enter into these plans at your own risk.
Right.
And so anything else, I think, even an HSA that is controlled by the government is really not, in the end, going to be our friend. It's going to want to control us in some way. That's what I love about the blockchain, because it disintermediates not only large companies, but it disintermediates the government and automates what's good, and it continues to automate that. And so once you're signed on to it or a member of it, as long as you agree to the protocol, it's going to automate the whole process for you and take out those people who want to extract from the actual care that you're trying to give. And then the direct primary care would be completely off that blockchain, would not be involved with that at all. That relationship still is sovereign. And the only part that would be on there would be the catastrophic part of the plan, which is the missing piece.
I think that's a really good summation, and I think that that if you that allows this, like you said, the sovereignty of the DPC docs to remain in control and independent enough to want to participate with something like that.
Right.
That's a huge part of it, because like I said, there's not enough DPC docs, number one, around right now, and the population you have are fiercely independent and don't want to get in the middle with a third party, and that may change, but we're all about the patients and saving money, and anything that would help do that still allows us to be independent, is a good thing.
Yes.
But the one thing I wanted to tell you, I don't know if you're probably aware of this, with the other thing that came up was the state waivers and how they're going to loosen the guardrails on those state waivers. They just shut down Idaho because it didn't stay within the guardrails, and it's almost like they designed the 1332 waiver with those strict guardrails in place almost to make the states fail at any attempts. So there's talk about loosening the guardrails, but what was interesting to me is they were talking, and I found out, I didn't know this, the territories, the U.S. territories, Puerto Rico, Guam, they do not have, they can innovate with major medical policies that do not have to comply with the ACA regulations and the 1332 waiver. So word has it is that the insurance companies that may have an office or are located, I'll be right in, honey, in the territories, yep, are starting to look at building plans that the states can use. The states can use these territories, these plans from that would originate from territories. So that's something else to keep an eye on.
I've actually had the opportunity to reach out to Cigna, who provided the high deductible catastrophic policy for Q Lions. God rest them. But they're very effective, low cost. And I've reached out to a Cigna counterpart in the Nashville market, and they are contacting their Pacific Northwest folks. Not that I really want anything to do with insurance companies anymore, but if they can get some idea of how that worked and if it was reasonable cost, because while I agree with Dr. King, and again, my wife is a member of a health sharing ministry, and I think they're wonderful. Some people want that for whatever reason, perverse reason, perhaps, want that insurance relationship. It's those that say, well, there's no guarantee that the health sharing ministry will pay, and according to the state insurance commissioner, Cigna has to pay. But at any rate, I think that's fascinating about what's going on in American Samoa and Guam and Puerto Rico. So that's a great potential option.
Well, the other aspect is the association plans.
Mm-hmm.
So
Yes.
the blockchain could become an association and take in employers like that, and then the DPCs could band together, and there could be a plan by which for X number of patients, you're paid so much, and the blockchain intermediates all that,
I understand, though, with association plans that they're state regulated.
Oh, no,
Am I wrong?
no, they come under ERISA.
You're talking about ERISA, employer. Okay.
Yeah. So those are federal and national plans.
The states can, because if you're talking about an association plan that employs a secondary insurance or a stop loss portion, most states regulate the stop loss. And so if they wanted to, they could shut down an ERISA plan in a state by regulating the stop loss to the point where it's not even viable. They've actually done that in New York and Florida.
Well, to the extent I know, stop loss insurance is something separate. It's not even. It's technically not even health insurance.
No, but I mean, if you're self-funded employer, you have to have a stop loss insurance unless you're big enough to take the risk yourself.
Right.
But I mean, you're right. If the alliance was big enough, they would need a stop loss. You're right.
It's not insurance. It's not health insurance. It's only meant to cover for extraordinary expenses that you might have beyond the budget that you planned for, right? So,
okay.
Yeah.
Yeah, it's just
but there are nuances to it. There is there are some details that somebody was explaining to me that because you're covering health, some regulation gets involved. So there is some detail that you have to be aware of, which somebody was explaining. Somebody who's very well versed in this, Megan in Oklahoma. She knows every little detail about this. That in some states it can the regulatory aspect can come in. But I see these association plans governed by ERISA to be the most promising because they don't have to comply with ACA, and size is not a problem with them because it could be a self-employed person who can join an association.
Mm-hmm.
So blockchain would have to work as an intermediary. So when somebody charges, let's say, $75 a month to the patient, there's a math involved that you're expecting X number of visits from that patient, right? So the blockchain could aggregate all that and work out like for how much they should charge, so that anybody who in that blockchain, any DPC could be used for a service, right? And the doctor gets paid by the blockchain. So I think there is some math to be worked out by which the monthly payment is not directly to the doctor, but to the blockchain. And doctor gets paid for the service per patient.
Well, I think that complicates it. I think if you completely extract the direct primary care from that, let each office manage that themselves. It's not difficult. I mean, we're used to dealing with hundreds of insurance companies and being, having certification. So getting just a member payment is pretty easy. That's why the cost of it is so little. So adding blockchain to that, I think, just complicates it and makes it more costly. But I think it could work for a health sharing plan, or like you said, that other idea. So
yeah, but regarding health sharing, there is Center for Health Excellence, which works as an intermediary with the health sharing plan. So it's not like you have to directly deal with them.
No, and I think Liberty just started reimbursing for direct primary care memberships. The patient just submits an invoice, and they're reimbursing the patient for their membership. I think Liberty just started that, and obviously,
Liberty does that independent though of the direct primary care practice.
Yes, so the patient finds a DPC practice, pays the membership, gets an invoice once a month, and submits it to Liberty. I think it's Liberty that did it, and Liberty reimburses the patient.
Kim, why do you think all insurance companies wouldn't support something like that? At the end of the day, it's like they're fighting themselves. I mean, they're dying to go to the doctor and be prevented.
Well, they're making money off of their insurance plans. They're going to lose money.
Insurances make money off of being opaque, because then they can create networks that are really bogus, PPO networks, and what they're selling is a price to enter that network and a supposed discount price to be in that network. That's how they make their money.
Sure, but the progressive ones, aren't they all starting to have, whether it's from an innovation arm or just some kind of other plan, basically trying to get you to go to your primary care doctor? It's not a high cost for them. It's not where they're trying to deny claims because it's really a big expense on their side. It's the smallest expense they have as far as claims reimbursement, right?
Well, it may be, but
not want you to be in one of these programs.
Well, being that most of the primary care are employed by hospitals now, it's not a very good business plan to send them to a hospital-employed primary care who's going to send them to their hospital-employed surgeon and their hospital-employed imaging service.
Right.
So they don't really, that's not where they can make their money. They make their money off selling a price. Now, that's guaranteed. They sell that price, they put that away, and the next year they raise that price and sell it again. So that's all they're selling.
You're saying that the fact that you're tied to these and tend to refer out or use these other services that are high cost for them deters them, and plus they lose this control to keep upping rates and doing all those evil things that they do.
Right.
But theoretically, if there was some plans out there that focused on being high deductible, like to Kim's point, the high deductible market is opening a window for DPC. If there were plans out there that actually focused on that and focused about carrying on preventative and realizing that it's cheaper in the long run for them than dealing with it when they go to the hospital, but we all know, like, the hope of preventative is it's going to, down the line, it's always less costly. The people that are getting savvy on that around data and
They're still trying to create a business plan. None of them are not for profit. They're all for profit. Is anybody aware of a not for profit health insurance company?
Yeah.
No.
Blue Cross Blue Shield.
Blue Cross. Yeah.
They're not for profit.
By name only.
Theoretically, they're not for profit. I mean, they can give people raises, right? That work there.
Well, Ben, the assumption is that they want prices to be low. I think that's the wrong assumption. They want prices to be high, so they can show bigger discounts.
That's right. They want to be able to sell that price.
Right. So the assumption that the insurance companies want to do the right thing is really upside down. That's not their intent.
So Liberty, what was backing? So Kim's example, though, Liberty made this leap. What do we know? What drove that?
Well, Liberty's run by the Mennonites. They have no intention for profit. Theirs is only a service, really originally for their members, to share healthcare costs and to, in some way decrease that cost by the fact that their members are living healthfully. And so that was their motivation for that. So that's, and I think you could put that in a protocol and automate those things so that, and you could call it a direct primary care health sharing network plan where any primary care physician could decide, I want to be direct primary care, I want to join this network, and there are now thousands of patients looking for direct primary care in my area to be able to join in this network. I mean, it has to be bootstrapped. It's just, again, it's the chicken and the egg. How do you bootstrap it?
Having one large token cell.
Well, that's true. You could airdrop tokens on you could start off with all the direct primary care current members.
Yeah, that's kind of what we're planning. I don't know the exact number, but that is the plan. Airdropping for X number of primary care physicians to step in and be that initial group of physicians to do this. So let's kind of get into that. What I know your idea on cryptocurrencies, but Kim, let's see, have anybody else in terms of having a cryptocurrency as a payment from a patient? Is that a no-go for physicians? What do you think? I know some physicians are for it. I've talked to a few, and they're for it. But some don't. Some still think Bitcoin is used to buy drugs on the dark web somewhere. So,
if I may ask a basic question, and maybe I missed it before, but is the intention of this enterprise to lower costs, improve access, or support primary care? I mean, where is the primary stress?
It is to decrease cost, and it is to optimize health.
So far we've been talking about DPC, and in my observation, primary care has never been the most expensive part of the system. Right? So you're really talking of nibbling at the edges, so to speak.
Well, the idea here is to get people healthy and to keep them there, to keep them away from specialists. Never need to go to these hospitals that are going to charge that just outrageous price for things. So the idea is to focus more on the proactive and preventative side of medicine versus that reactive sick care side that we're all having right now. So starting with primary care, I think that's a good base to grow off of. There's a lot of issues that can be stopped at primary care physician that never need to make it any further. So that's kind of the topic of this talk is that base service that we're looking at.
Well, maybe what I'm thinking, Brennan, is the blockchain, like I said, just for catastrophic care and also for, surgeries. I mean, I'm talking about hospitalization, the things that bankrupt people. Those could be priced on the blockchain. You could also not only price them, but transact on the blockchain based on, some type of evaluation of maybe the specialist somehow. I don't know. But at least be priced initially, maybe just priced, and then compete on prices. Something like what Surgery Center of Oklahoma does. And it was be essentially blockchaining the Surgery Center of Oklahoma nationwide, so that those types of things could be completely out in the open for everybody and networked. And then once that really gains a foothold, then maybe you could do some of these other things. But I mean, you need the people, you need direct primary care first, I think. And then you can add some of these other things you're talking about.
Yeah. I talked to Dutch Rojas the other day about his surgery centers and what they're doing. And they're looking at something along the lines of futures contracts for surgery. You go into self-funded employers and say you have, 100 knee surgeries, knee replacements or something for X number of employees. Well, they're actually purchasing an option on this. And you might not need those 100 knee surgeries. You might only need 50. So you actually, each one of those options are a tokenized asset that you now can trade or sell to another employer for, basically you can get rid of that. And that's a concept that we're considering, are these almost a derivative type healthcare contracts for employers. So that's one thing we're talking about for surgeries on a blockchain, is saying, okay, this surgery is $25,000. You have $25,000 in your account. As soon as the surgery is performed, both parties agree on it, that transaction can happen immediately. Everything can be documented. You can find value on both sides. So yeah, that's something that I think needs to happen, is having transactions like that.
Yeah, that probably would be regulated by the SEC. Somebody would regulate that. But just putting a price on and being able to transact based on a price, that's not regulated right now. So it seems like that could actually happen. I'm just trying to say, how can we do this to keep it simple and grow it?
Well, yeah. So in regards to this option idea, actually United Health had come up with this way back in 2008, and then it was banned by ACA. So the idea is that patient could buy an option, and I suspect that it could be an alternative to catastrophic insurance. So if you buy, for example, let's say you pay $75 a month for your health services, and if you have the option to buy more when you have an unexpected expense, let's say you have cancer and you need to pay more, that option should kick in. And then it would mean that you'd pay more, but it would be not a disproportionate amount. So let's say you buy an option $10 every month and you have cancer, then you start paying $100 a month and you get treated for cancer. So that, I suspect, could be an alternative to catastrophic insurance.
Mm-hmm. Yeah, that's a similar idea, that kind of what we're trying to envision is something along the lines of that, where you can purchase this cancer option. Let's just say a 30-year-old can say, okay, I have a history of cancer in my family. I'm going to purchase this cancer option contract, saying that if I get cancer within the next 20 years, it will be covered at, 50% off. And like you said, you're paying $10 a month. And well, if you actually never get cancer in that 20 or 30 years, well, you're just covered, and that was your catastrophic plan. And when that option does expire, I don't know if you can sell that. I don't know how that would work. But the general concept is there. You have derivatives contracts for all kind of different industries. The same concept is to cover risk. So having this model in the consumer healthcare side of it, it's definitely innovative. And I think it's something, maybe not, it would probably have to be more for surgeries, I think, to start off, to make sense. But it's an avenue to go down. And talking about regulation, I think that would definitely be Probably a security. Is the way SEC is looking at everything crypto related now.
Well, if it's done within a blockchain, then you can skirt around the health insurance regulations by saying it's for expense, right? I mean, you're expecting a higher expense for your health. I don't know whether it will necessarily be regulated. It might be helpful to go back to the previous episode with United Health and look at how that option idea was regulated or not regulated.
Yeah, I'll definitely look into that because I think there's something here because.
Yeah, I'll link you to an article that was there published, and I posted it on Support Market-Based Healthcare group. So I can link you there and you'll get that article.
Let's see.
Is this basically like automated underwriting for pre-existing conditions, but you don't automatically make the membership fee higher? You just like offer it intelligently instead?
So it's like this, because it's an option, it won't be very highly priced because when you actually use that option, you'd be paying higher amount. So as I was saying, you pay a regular $10, let's say, it'd be very low, $10 a month. You may end up paying it for 20 years till you get cancer. Once you get cancer, then you pay $200 a month or $100 a month. The exact math would have to be worked out. But because you've been paying $10 throughout, it won't hit you suddenly. It won't be a sticker shock, right? Because you'll still be paying about $100 per month and get coverage for cancer, let's say.
Well, another possibility is something like Singapore does, where they have siloed savings accounts. Mm-hmm. So you would at a certain age, maybe at birth, you would start a health savings account for yourself, and in a second account you would start a health premium account, healthcare premium account, and then a third account would be healthcare premium adjustment account. And so you would have something available if something did happen where your premium would actually go up, but you would then tap into your healthcare premium adjustment account. And then if you didn't tap into any of those throughout your lifetime, that's your retirement savings account.
It makes sense. It seems fair. The consumer side of me says we're getting down the Microsoft path of marketing stuff, and it's complicated to people, and there's a million tiers and options they have to pick to make their plan. And the savvy person that feels like they're picking and choosing what they're getting covered for may like it, but you're probably going to overcomplicate it for the average consumer. It's like, I don't know my history. I want to not think about it and be covered. Now you're making me piecemeal, am I going to get cancer or am I going to have this? Diabetes, and diabetes will end up in 10 years, 5 different kinds of diseases. And it's going to, so you start tying it to clinical and medical stuff and knowledge. Doesn't it get confusing?
It does. I think so.
Here's a concept that I want to briefly mention. I'm not going to go into all this, but it's something I just drafted up yesterday. But Lauren, you mentioned something like a Singaporean model where you have this, what I'm calling a cradle to grave savings account. When at birth, everybody gets a personal health asset, and this is a crypto asset on the blockchain. It's where almost like either an alternative to an HSA, or like I mentioned before, it is an HSA to some extent, where you can invest a portion of your funds from your HSA into this crypto model. But this stays with you, and based on your genetics, your variants in your genome, and certain health conditions that you maybe have, hereditary conditions. Let's just say you have a higher probability of getting heart disease in your future, or a higher probability of having cancer. Well, you're actually segmenting a percentage of your membership. Say 10% goes to a cancer option, or 10% goes to a heart attack option, or something along those lines, where you can divvy out just buckets of funds in your personal health asset to act as that investment vehicle for later on in life. And if you ever do need it, it has been sitting there growing with, as you can see, with the cryptocurrency you're generating from the rest of everything in Citizen Health. But that's just something I just wanted to throw out there, thinking that this is kind of modeled after Singapore, because I love what they're doing. I think out of any country in the world, they're probably my favorite in terms of what they're doing. And yeah, so I think having their model on a blockchain would be extremely beneficial. I'm surprised nobody's even talked about that yet. Of course, they may be doing something like that over there. I just want to throw that out there and kind of get some thoughts going.
And you were into the question about confusion. That all could be automated based on the type of crypto asset. Just like you said, it would be automated. The other thing is it could be shared. If I want to share my asset with a family member or with somebody else, or even vote on sharing, it could happen on the blockchain.
Mm-hmm. Yeah, that's huge right now, is the sharing economy. I mean, you look at all these people on GoFundMe. People have a $50,000 health medical bill, and they raise it just on GoFundMe because people have it's just the nature of our culture now is to help others in need. And if you can actually scale that out, I think there's like $400 billion that is donated to healthcare related charities. And if we start organizing this stuff into a crypto environment where we can use this money as a tool versus just scattering out everywhere, you can do a lot of good with it. And especially
for like a cancer asset, you could actually say, okay, this maybe the American Cancer Society wants to contribute, 1 million cancer asset tokens to that blockchain, and then that's available for anybody who who can use it and voted on by the members.
Yeah, that's at the same time. If you look at, let's just say we have $10 million left over at the end of the year from this Citizen Health model, and what do you do with that 10 million? There could be other people in need, and the community could vote on that. Say, okay, we're gonna help out these 50 people, or reinvest that back into research and development for finding cures for specific diseases. It opens up a whole world of possibilities when you do something like this, especially when you have the community voting on it, and by their vote, it actually could. They're incentivized to vote correctly because later on down the road, that could benefit them.
And everybody can see the vote.
Exactly. Everybody knows what's going on. Complete transparency.
Okay, guys. Sorry, I have to leave. Head back next time.
Thanks for joining us tonight. I appreciate it. And we do need to kind of wrap this up. This is kind of getting late for everybody. I would love to get in the technology side and the software side of healthcare. When we talk about that, we might have to make another.
There's your topic for another meeting.
That's right.
I've got a 6-month-old grandson that's wanting to see me, and he's getting ready to go to bed.
Oh yeah, I got it in mine. I'm getting messages popped up on my screen too. So, all right, everyone. Well,
thanks everybody.
Thank you.
Thanks everybody.
Happy Easter to everyone.
Yeah, happy Easter.
Thank you. Thank you very much. Bye-bye.
Thanks.